I'd like to once again thank all the folks who really organized this day. It's a lot of work. Cindy Fletcher in the back, waving her hand, did a lot of work. Mary Ellen Corrigan, Dr. Cairns, and actually there's a whole squad of folks who had meetings to get this organized. It takes a lot of work, and we really appreciate it. I just get to fly in here and set everything behind time. So, so today's talk is going to be a little bit different. It's titled "What's New in CF," and usually when I give this talk, we try to cover a lot of ground, covering a lot of the new therapies. It's getting to be too big to cover in a 1-hour session. So what I'm going to try to do is give you a little bit of a feel for how you can get more involved in CF. I think that's the biggest thing that's new this year, is that there are more opportunities for families and patients with CF to get involved in the effort as we move towards a cure. So I'm going to show you a little bit about how you can self-educate, and I'm also going to tell you a little bit about what we're doing at our center, and I'm going to focus, out of all the different therapies, I'm going to focus on the new therapy that's just become available that many of you probably want to learn about, the Caistin product. So we're going to focus on that. On your tables, there are these little, almost looks like remote controls. I have a couple of questions, and you'll have an opportunity, if you can point towards this little disc up here. We'll take an audience participation poll on a couple of questions just to see where you're at, and we'll compare it to how other patients and families have answered. So with that, we'll get started. A number of my slides are taken, at least in part, from the CF Foundation, and I have the logo on the top of all the slides here. So, oh, and one last segue. Last year, I decorated most of my slides with little pictures of salt crystals, if some of you remember. This year, we're going with origami. Two of my sons like to do origami, so we have a few of their pieces in here. Okay, so our teams, that's one of the things that's new, is that our teams have grown and changed, and things have been reshaped a little bit over the last year. I just want to thank all the folks who've joined our CF teams on both the pediatric and adult side. And kind of ironically, the adult team has gotten younger. So we have a lot. You met Katie, who gave a talk, and Marissa Stanley is in the back. This is her first CF Education Day, but she's settled in very nicely with the team. The other big news for the adult team is that Karen DeRose now has pretty much a full-time position doing CF, which took a lot of work with the hospital, but we're finally there. For the pediatric research team, I don't know if Carrie Gill is here. I haven't met Carrie, but she's going to be joining the pediatric research team this upcoming month, right? Is
Yes.
Anna? Yeah. So we're excited about that. Obviously, we're sad that Tim Messett moved to Providence, but he did a great job, and we're sure that Carrie's going to fill in nicely as well. Is Tina Manley here? No. Tina Manley has been working on the adult research team, and she's going to continue working and training Karen as Karen takes part in our adult research efforts. So this is the first and last time that I'm going to show you this slide this year. Pretty much every year that we talk about what's new in CF, we have what's called the therapeutic pipeline, which is championed by the CF Foundation. And the nice feature of this is that you can look at a broad range of areas where we're looking for ways to improve the lives of patients with CF. So we're not just putting all of our energy into one approach. We're looking at, on one extreme, looking at gene therapy. And these slides, some of them are going to be busy or small. We're going to have all this recorded, so you don't have to worry too much about taking notes. All the way on one end, we have gene therapy. And although it's kind of lost a lot of the publicity, there are still people working very hard on trying to get at the fundamental defect in CF, which is an abnormal CFTR gene. So I think last year I talked a little bit about compacted DNA. There are no big breakthrough reports on that, but there's some very strong scientists working in that area. And what's probably the next step up from gene therapy is actually trying to fix the workings of the broken CFTR gene, either by trying to get more protein to the surface of the cell or trying to activate it. And we actually participated a little bit in this VX770 study. We were a little disappointed that they closed the study to enrollment so early. But we're going to keep an eye on that compound. You may actually read a little bit more about that in the news. An area that's near and dear to my heart, and we've been actually quite involved in this work, is looking at ways to restore airway surface liquid. One of the problems in CF is that mucus sticks to the wall of the airway, and if we can add some fluid to lubricate that mucus to help it unstick from the wall and also move up out of the airway, we think that we can do a lot of good. We can reduce infection and reduce airway remodeling. So there are a whole host of compounds in the pipeline, and actually one of these we're involved in that's going to be presented at this year's CF meeting is actually looking quite good, but it's a little early for me to present the data on that. That's the inhaled mannitol. The other one is the danufisol, which acts to promote secretion of fluid into the airway, and that one's also looking promising. There's a manuscript that's being sent into a good journal, and again, I can't speak about that one yet because it's not published. Now, the anti-inflammatory story is an interesting one in that we think that a fundamental problem in the CF airway is not just that the mucus is sticky, but there's unregulated inflammation, which causes swelling of the airway wall and scar tissue to develop. And a lot of people are spending energy on that. And you know, you've heard a number of years ago about ibuprofen. That medicine still has effectiveness. It's been well published, but it's kind of a difficult medicine to take. And unfortunately, it doesn't seem to translate into the adult world. So most of our adult patients are not on ibuprofen. And this whole slew of other medications, at this point, we have not found anything that really works. So I'm not going to spend much more time on that, but it is an area of focus. The area where I think things are really happening in CF right now is with anti-infective therapy, and the new medicine, Caistin, falls into that category. And I'm going to tell you why I think this is going to really make a big difference. So this part is near and dear to my heart. It's probably because that's what I studied in the lab, and I think that also it probably is going to work very well for early lung disease with CF. The anti-infective, particularly for our adult patients, this is what's going to make a real difference right now. And I'm going to skip some of the other areas on the far ends of the slide just so we can move along. So what is this mechanism by which we study all these new therapies? Well, the CF Foundation invested a few years ago in trying to get multiple centers across the country involved in clinical research. I was rather astounded when I started reviewing some of the papers that are coming out on these new therapies that we're studying 200, 250 patients in a trial. If you look in the paper about something that's studying high blood pressure or strokes or cancer, they have thousands and thousands of people in trials. And that's going to be the bottleneck for new therapies in CF. It's not going to be for the lack of ideas. It's going to be for not being able to get enough patients into clinical trials. And in fact, the Caistin, the data was out several years ago, but the FDA was really hesitating on approving the medication because they didn't feel that enough patients were in the study. So the CF Foundation decided instead of having 15 or so centers across the country that would be involved, centers like these green dots that are doing basic research, they wanted to roll this out to sites all across the country. Now, we're in a fairly dense area for clinical research centers, but I think it's a great opportunity, and it's a a great thing for our patients in Maine that we have a center in Maine that provides research opportunities, that you don't have to go to New Hampshire or Boston to be involved in a clinical trial. I noticed looking at this map that there are several states, big states, where there aren't any clinical trial centers. Imagine being somebody in North Dakota and having to go all the way to Minnesota to be involved in a trial. So I think that we're fortunate that we have a center here, and we want to keep that going. Participant enrollment in clinical studies has gone up dramatically, but we think that the need is actually going to be more in the ballpark of 8 to 10,000 for all the different studies that are being rolled out. This is a nationwide. So get your little clickers handy, and we're going to see if this works. First question is, what are the reasons you have never participated in a CF research study? And I understand that there are many people here who would not qualify for that because they don't have CF, but make this hypothetical. So answer A would be, I am too young. B, I have not qualified. For example, lung function's too low, or infection or allergies. C, I was never asked. D, busy with work, school, or distance. E, I am worried about side effects from studying medicines. Now, so let's see if we can get this to work here. And we're going to go with E. I'm going to give us about 50 seconds since it's our first one here, okay? So what you do is you take your clicker, decide which one on that panel you agree with, and just point it towards here and click away, okay? Start clicking. Wow, it looks good. People are actually, we got 23 votes, 24. Okay. I think it may take your second answer. I'm not sure. Be more decisive. All right. Okay, so we've got about 20 seconds left. So what's going to happen when we're done here, there's going to be a little pop-up graph that should display when it's finished. And we'll just see what the distribution is. I'm curious because I want to know how we're doing. 10, 9, 8, 7, 6. I'm going to make the second question a little bit shorter. So this is our learning curve here. Okay, so it's pulling up the data. Uh-oh. Oh, here we go. Okay. So kind of even across the board. Let's see if we can remember what these answers are. So B. So a fair number of people feel that they haven't qualified based on illness. Interesting, C, never asked. So a fair number of people have never been asked. And worried about side effects. Okay. Well, we're going to talk a little bit about this in a few minutes. So, all right, let's see how things came out nationally. So nationally, so we're actually maybe doing a little bit better than nationally. At a lot of centers, people just haven't been asked. So we do want to make sure that when things come down the pike, you may get things in the mail just saying this may be something that you're interested in. We're trying to also get a feel for what our patients would like. There are going to be different types of studies that come down the pike, and we have to say we're interested or we're not. And part of the interest comes into how many people do we think would participate. If we don't think anybody, or maybe just one person, it might be hard for us to ramp up for a study. So look forward to getting some mail. The other place where you can talk about clinical studies is when you come into the office. And I'm also going to give you some hints on the internet for how you might be able to scout out some studies. So before we go too far, I want to thank some of the people at our own center who over the last few years have participated in clinical studies. We've asked all these people whether they're okay with having their names out there. So if you do participate and you don't want your name on the slide, we won't put it on. We've actually had a couple of people who wanted to keep it private. We actually have a couple of people who are no longer with us. and I actually got a picture today, so I figured I would show you one of the folks who was Matt Altimus. A few years ago participated in a trial, and actually he participated in a trial for a medicine that I think will be rolled out at some point. So it's really, I think it's exciting. I've never participated myself in a study, but boy, it seems like it would be a fantastic feeling to see something come to the market where you actually were part of the effort of getting it through the process. We also had a local study done at our hospital with one of our fellows, and we had a few patients involved. And if you think this is a lot of patients, many more of our pediatric patients have participated in clinical trials. We just don't have them on the slide today, but maybe next year. So what's the CF Foundation doing to raise awareness in clinical trials? I'm going to provide you with phone numbers and web links. And of course, you don't need to write all these down. They'll be, I think these are in your handout, or they'll certainly be on the video made for today. But you can get information on clinical trials at this number. And if you go to the CF Foundation main website, there are a lot of resources for clinical research, and I'll walk you through some of those. On the website, they have frequently asked questions about clinical trials. And as I'll point out later, there's some great videos. This search tool is really nice. I think we'll see on the next slide how you can kind of walk through that. So you can go up to the top of the website, you can go to Research Overview and look under Clinical Research, and it'll pull up some of the studies. And they give a little overview about the rationale for each of these different studies. So you can search by state, and you can also put what your age is. There are going to be certain studies that are more targeted towards pediatric patients or adult patients. Here's a study that's completed now, but you can actually search down through them, and you can drill down and get a little bit more information about them to see if you're interested. One of the things that I thought was really nice is that they have some little, now with YouTube, it's a great way to kind of meet face-to-face with other CF patients who've gone through the experience. And there's a young woman who's very articulate. She was actually at the national meeting last year. She's a runner and also a rock musician. And she got up there and was playing drums and making fun of Bob Bell, who's the head of the whole foundation. She has a great little video that I recommend that you check out at this site. So now we're going to shift gears and get into a little bit of detail. I may see some sleepy eyes out there, but I wanted to do more detail this year on a particular medication for a couple of reasons. One is I want you to understand that when we do these studies, there's a lot of information that we get from them. And there are a lot of questions that are asked besides, is it feasible to give this medicine? And does it improve lung function? When these studies are designed, we get a tremendous amount of information, and there's some very smart people who think up front what we need to do to get those answers. So first off, what is Caistin? Well, it's an antibiotic called aztreonam. And aztreonam can be given intravenously. We've used it a lot of times in the hospital for many of our patients, and it works great. It works particularly well for people who have penicillin allergies. So it's kind of nice that it's available for a lot more patients than some of the meds that are commonly used for CF that cross-react with penicillin. One of the tricky things is that the normal formulation for aztreonam for IV is kind of irritating to the airway. So they had to create a new salt, which is this lysine salt, and that's why it's called, one of the names for it is AZLI. It's aztreonam lysine for inhalation. So that's the generic name of it, and Caistin is the trade name, okay? So you may see these things used interchangeably. So in the medical literature, they tend to not want to use trade names. So if you're going on the internet to look up the actual articles, you're going to see aztreonam lysine. And one of the first articles that came out was in the American Journal of Respiratory Critical Care Medicine. It's kind of the New England Journal for lung doctors. It's a very well-respected journal, and you don't get articles in there unless you've done a very good job. So this study got quite a bit of press, and to be honest, I think that the investigators, when this was published, just kind of assumed that this drug would then roll out pretty quickly because it was published in this journal. But as I mentioned, the FDA had concerns about the number of people enrolled in the study, and they wanted more data, so there are subsequent studies done. Busy slide here, but I think it's an important one. This is the way many drugs for CF are looked at. We look at lung function, and if it's an antibiotic, we want to see, does it actually kill the bacteria? Do the bacteria go down in number? One of the unique things that was done with the ASLE trials, and it's kind of rolled into a lot of different areas of medicine, is we not only look at lung function and how many germs are killed, but we want to know, do patients feel better? So there's an instrument called the CFQR, which is shown up here, and that's a quality of life instrument. So they ask about breathing symptoms and how your energy level is, and that, I think, is something very important. You want to know, if you're taking a medicine, do you actually feel like it's helping you? And so in this study, they've already defined that if you go up by 5 points, that's considered something that patients really notice. And so the top graph here is showing 2 different doses of the ASLE compared to placebo. Okay? And most people don't like to be in the placebo arm of any study, but it's very, very important, because if you don't have a placebo, then it's hard to know whether a medicine actually works. And one of the things I really liked in that video clip from the patient who's participated in studies, she said, you know what, I actually, I don't mind if I get the placebo, because if I'm helping get this, if we find out that this medicine really works and truly works, then it's going to help my friends with CF, and I'll also get to use it too once it's ready. So I thought that was a really neat attitude. I hadn't really thought of it that way, but the placebo is very important. Here we look at lung function improvement. Clearly a very significant improvement in lung function during the study time, and these gray boxes are showing when the medicine is given. And as part of the study, what they did was they took people off medicine to then see how they did. Did the lung function go down? Did they have exacerbations? And we'll look at that in a moment. But you can see that actually lung function did start to drift down, just like it does with Toby in between treatments. And this is looking at the number of bacteria. And it may not look too impressive to you, particularly in the back of the room. It doesn't look like the bacteria go down that much. But this is on something called a log scale. Does everybody know what a log scale is? It's multiply. It's not like going 1, 2, 3, 4, 5. It's like going 1, 10, 100, 1,000. So each line is a factor. So even small slopes like that can be a big difference. So generally speaking, that they're reducing the bacteria by about 100-fold in these studies. So this is another interesting way of looking at things, and that is how many patients didn't need to go on another antibiotic. Now you might think, why don't we just look at exacerbations? And I don't need to tell you how hard it is to know whether you're having an exacerbation. Anybody in this room with CF knows how hard you're trying to think, am I really having an exacerbation? And you're talking to your doctor, do I really have an exacerbation? And we have score sheets and all that. But really the trigger point we want to look at is when are you putting somebody on a different antibiotic? And so patients who are on the ASLE, it looks like they were going about 20 extra days without having to go on a new antibiotic, which we think is clinically significant. What are the side effects they saw in this Blue Journal article? Well, this is another reason why it's very important to see the placebo in these studies. And these studies are tough to do. Every time an event happens, you get a cold or an earache, somebody has to write all that up, partly for this reason here. Okay, we want to see, do people have more cough or wheezing as compared to placebo? And what's shown on this slide, small numbers, but you can see that in the placebo group, 34% of them had cough. Well, that comes with the territory. So if you didn't have the placebo group, you would see on the package insert, well, 27% of people have cough. And you say, boy, I don't know if I want to take that medicine if I have a third chance that I'm going to be coughing. Well, it turns out it's just about the same as placebo. And so there were no areas that looked like red flags where this medicine was causing other symptoms. Again, this is all in your handout. Now, another study, we're going through a lot of detail on this, but part of the lesson is to see that this medicine's been studied pretty intensively. They wanted to look at the efficacy, which means the effectiveness, and the safety of inhaled aztreonam. And notice it says in patients with Pseudomonas. I can't overemphasize that it's very important for you as a patient to know what your cultures are. And if we're not telling you what your cultures are, you should be asking us, okay? Because we're learning more and more that our therapies have to be targeted. If you have staph, for instance, then this medicine is not the right medicine for you, okay? So anyway, this is specifically in patients with Pseudomonas. Now, why did I put this slide on here? I was just astounded again to see that there were only 253 patients screened for this study. It's pretty hard to find statistically significant differences between groups when you have such a small study sample. So the fact that they were able to find statistically significant differences means that the effect size was pretty good. I know that we have at least one accountant in the room who's good with numbers, so they know that the more numbers you have, the tighter your error bars are going to be, right? So just think that we had at Maine Medical Center, I believe that we had 4 or 5 people in this study. This study was done across the whole country. Think of Maine's population compared to the population of the country. We did pretty well to get 4 or 5 people in the study. So you should applaud for yourselves. We did a good job in Maine. Just to show you that the results are consistent, that we see again while patients are on study drug, there's almost a 10% increase in this particular study in FEV1 compared to placebo, a big drop in the number of Pseudomonas organisms, and an improvement in quality of life. So the first study that I showed you was an international study, and this one was done in the United States exclusively. I'm sorry, reverse that. This one was the international study. The Blue Journal article was in the United States only, and we were mentioned in there. Okay, what else can we look at here? We can start breaking patients down into categories. Is this a medicine that we should be using with people who have severe lung disease? Does it work better in children or in adults? All these things were looked at. And good news is it does seem to be effective in all the different subgroups that we look at. But interestingly, look at this effect in pediatric patients. So this is looking at the quality of life scores. So I remember I mentioned to you that a score of 5, a change of 5 is recognizable to the patient. So in that group, we're looking at 15. So, and I can only go anecdotally by the patients that we've had from the studies. Some of them felt dramatically better on the medication. Change in FEV1 seems to fall out a little bit less than 10% in this study. This is technical. I'm actually putting a couple of these slides in because I want to talk to other lung doctors about this, but an important feature of using an antibiotic is you want to be at a certain level that really kills the bacteria. And when we check your sensitivities, when you come into the office and we say, oh, your germ is sensitive or not sensitive to tobramycin, there's a number that goes with that. And that number means what's the level of this medicine that's enough to kill the bacteria. And that level is determined by what's safe to give in the blood. So with some medications, if you crank the level up too high in the blood, you get problems with hearing or kidneys and whatnot. So we know that if the number on your lab reports is too high, then we say the germ is resistant. Okay, but conceivably, if you could put that medicine in the airway where it's not toxic to the kidneys and everything else, if you can really crank it up high, you could actually kill that germ even if it's listed as resistant on the panel. And that's actually what we do with some people who are on Toby. You look at the report that says resistant to Toby. Why am I still taking Toby? Because we can get very high levels in the sputum or in the lung, much higher than we can in the blood. So just to give you an idea of what the numbers are, here are the numbers for the level in the sputum on different days of treatment. So you see 530, 677. When we're talking about resistance, on your lab report that comes back to the office, the number is like 8 or 16. So we're way above that in the sputum. So there's good hope, even if you have an isolate that says resistant to aztreonam, you might be a candidate for this medicine, just like with Toby. Does that make sense? Can people nod if that? Okay. Okay, so one of the concerns I've always had, and I know I have a couple of patients who've asked me this question, well, what happens if I'm staying on this medicine? Is it going to get more and more resistant over time? And so in these studies, they looked at this. So patients with increasing or decreasing susceptibility, that means sensitivity to aztreonam from baseline. And I'm not going to walk through every line on this, but you can see that these are pretty much horizontal. There is some up and down movement along the way, but overall we're not seeing that the germs are becoming more resistant over time. And that's partly because of the strategy of putting people on it and taking them off of it to give a recovery period, okay? Just like with Toby. I'm going to give you a little bit more data that came from in poster form. So this stuff isn't all published, but I thought it was very nicely presented at the North American Conference last year. And they looked at, for instance, resistance to other antibiotics. So patients who are on this inhaled aztreonam who become resistant to Cipro or who become resistant to aminoglycosides. And again, you can see these lines are pretty flat, which is good news. You're not conferring resistance to other antibiotics by using the aztreonam. The other thing we want to look at is how many patients have Pseudomonas. Does that rate go up, and does the number of colonies go up over time? And just like they saw in the tobramycin trials, the number of colonies goes down during treatment, goes back up off treatment. So we have this oscillation over time, okay, which is just like what we see with Toby. Do patients get more resistant to tobramycin over time? Again, I think this is a little bit of a duplicate of the previous, but this really gives you the hard numbers. What's the actual number for the sensitivity to tobramycin? And pretty flat over time. Certainly not going up. If anything, it's going down. Okay, this is one of my few homemade slides, you can really tell. But those are supposed to be angry Pseudomonas organisms. Okay, so those are angry pseudomonads. And chronic airway infection in patients with CF is hard to treat. We face an ongoing battle and need new weapons all the time. Okay, so we have these pseudomonads sitting there in colonies in the airway. And what we're doing right now is we're zapping them periodically with tobramycin, and then we have people on azithromycin chronically. That seems to affect the virulence of the organisms, meaning how angry they are and how much inflammation they cause. And the other part is it affects their growth pattern so that they don't they don't keep growing up in number. We keep stamping them down and then they regrow. But the problem is that they do regrow. So here's showing the the shrinking pseudomonads who are still angry, but they look weaker because, do they look yellow back there to you? They're yellow, okay. And then over time, over that 1 month time that you're off the Toby, they start coming back. And a lot of patients tell me during that month off, I get kind of anxious because I just feel like things are building up again. And sometimes we'll try to trick things and go 2 weeks on and 2 weeks off, but we're always worried about that time off. Okay, so one of the other strategies that we can do is a multi-pronged approach using medicines that have different mechanisms of action. Just like what I'm talking about with that aztreonam, it doesn't interfere with the Toby sensitivity. So having somebody on the aztreonam doesn't make them more resistant to the Toby. Okay, so you can then cycle between Toby and the aztreonam every other month. And so the idea here is we turn this yellow guy into even paler when we use the next antibiotic. And we actually have other classes of antibiotics. We're starting to look at things like inhaled ciprofloxacin or inhaled levofloxacin, which is related. There are a whole host. Remember when I showed you that pipeline, there weren't just 2 things on that pipeline. There were like 4 or 5. Okay, and some of them look very promising. So we have this third punch kind of turning pseudomonads into little ghostly characters. Okay, so this is a slide. This is another homemade slide. It's not going to be published in any article, but I kind of think in my mind, well, how do these different therapies compare to each other? What's the lung effect that we get? So what I did was I looked at the different articles and found what's the range of improvement in lung function that we see with these different therapies. So over on the left side here, we have hypertonic saline. And some studies would say that maybe the effect is even lower, but all of these therapies seem to reduce the number of exacerbations. And we think that's a key thing to keeping people healthy with CF, is that when you get the exacerbation, we think that there's some scar tissue that builds up in the lung and it makes you more susceptible to permanent drop in the lung function. So we want to try to minimize those exacerbations. All these therapies seem to reduce exacerbations. But if you look at the range, they're all kind of in the same ballpark. Okay, the inhaled aztreonam is another one. The Toby may be a smidgen above the rest, but we think that there may be, it's still too early to know, that there may be some long-term additive benefit to having multiple therapies together. So for instance, having somebody on the pulmozyme with the Caistin or pulmozyme with the tobramycin will give long-term stability. Okay, so the next question, get your little clickers out. So this last question is going to be about why would you want to participate in a clinical trial? And I think I'll just leave it like this. So to receive better care would be A, to have early access to new medication, B, to help find a cure would be C, to receive payment for time spent in the study. You're not going to be able to make a career out of that, by the way. And E, to receive free medication. Okay, so let me see. Hold for 1 second. We're running into technical challenges. I'm going to make the time 30 seconds this time because I think we're pros at this now, right? Okay. Okay. There may be a couple of clickers that weren't working, but were some people just repeatedly? Okay, so let's see what we get. So C was the biggest response. To help find a cure. That's great. And I think that that's a big one nationally. Let me just see. Help find a cure. That's the biggest answer. So that's great because, you know, when I think about things like heart attack research or stroke research, they have 2 big legs up on us. One is when you come in with a heart attack, sometimes somebody approaches you when you're in the hospital that you have the choice to say yes or no, but you're a captive audience for that question, okay? And it's oftentimes a very limited commitment. You're committing only to a short period of time while you're in the hospital. Plus, there are millions of opportunities for researchers to ask people to participate. So it's very easy to get those big numbers that they need. But in CF, there are only about 30,000 people in the whole country. And some patients, they don't qualify for whatever reason. They're either too young, or they're not feeling well enough, or they don't have the right genotype. So when the right opportunity comes along, we only ask that you just think about it, because you're all in it together. I think that what's new in CF to me this year is that I'm realizing more and more each year how much it requires you to be part of the mission. You know, we can only provide the opportunities, but you guys get to share the real victory, because you're the ones who move things forward the most. You are the key. And the last slide actually shows some of the pamphlets that the CF Foundation has available. I think, Anna, you have these in the clinic. So if people have questions, yeah, we have posters. There are also handouts. I think nowadays the written materials are less engaging to people than the internet. That's why I put some of those links on. There are actually some very nice links on the CF Foundation website with patients talking about their experience. So with that, I think we'll finish, and if there are any questions, we'll open up the floor. Thank you.